20% of the stable patients. Actually, what is the illusion of stability in heart failure? About 20% of stable patients, that is those patients who had no prior hospitalization in paradigm heart failure trials, they had a primary event. And 17% during the course of the trials, they died. Of stable patients, so-called stable patients who experienced their primary event, death preceded heart failure hospitalization in 51%. And 60% of these deaths were sudden cardiac death. So what we can conclude is ARNI should be started as early as possible without waiting for deterioration to occur. So as per the recent guidelines like 2002 ACEI, in patient with heart failure with reduced ejection fraction and NYHA class 2 to 3 symptoms, the use of ARNIs is recommended to reduce mortality and morbidity. And in patients with previous or current symptoms of chronic heart failure with reduced ejection fraction, the use of ACE inhibitor is beneficial to reduce morbidity and morbidity only when the use of ARNIs is not feasible. And lastly, in patient with previous or current symptoms of chronic heart failure with reduced ejection fraction who are intolerant to ACE inhibitors because of cough or angioedema, and when the use of ARNIs is not feasible, then only the use of ARB is recommended to reduce mortality and morbidity. So what we can conclude is when ARNIs use is not feasible, then only we should use ACE inhibitors or ARBs. Now the next question is acute decompensated heart failure different from de novo heart failure? So de novo heart failure is a distinctive phenotype from acute decompensation in chronic heart failure. Acute decompensated chronic heart failure is like older population, worse baseline status and lab findings. They have known history of underlying heart failure. Whereas de novo heart failure, these are the patients, they don't have any previous history of heart failure. The acute decompensated chronic heart failure means they are already having ischemic heart disease, COPD, AF, diabetes or stroke, or history of CABG and PCI are more frequent. Whereas de novo heart failure, like these patients, they don't have such history. In such cases, trigger event is like poor compliance of medication, resistance of medication, infection, excessive water or salt intake, cardiovascular complication, surgeries, alcohol, digitalis. Whereas in case of de novo heart failure, cardiac ischemia or valvular incompetence, like sudden acute MI, acute MR, sudden viral myocarditis, or toxic insults, they produce de novo heart failure. So the clinical presentation is sudden onset cardiogenic shock or acute pulmonary edema, whereas acute decompensation involves dyspnea, orthopnea, lower limbs edema, ascites, weight gain. Here, the main pathophysiology is pulmonary and systemic vascular congestion caused by LV dysfunction. And there is a maladaptive neurohormonal activation, which leads to fluid overload and redistribution. In case of de novo heart failure, there is an acute hemorrhagic dearrangement caused by LV systolic dysfunction. Acute hemodynamic derangement caused by acute LV dysfunction.